ST elevation myocardial infarction, STEMI. Greg Johnson, MD, FACC, FSCI. Epidemiology of acute myocardial infarction. Coronary heart disease. Leading cause of death in high or middle-income countries. Leading cause of death in the USA. Rates of death from CHD have declined in most high-income countries. Rates of death from CHD have increased in the developing world. In 2004, CHD became the leading cause of death in India. It is estimated that 1.25 million Americans have an acute MI each year. ST elevation MI accounts for 30 to 40%. In the early 1960s, prior to the era of cardiovascular intensive care units, in-hospital mortality was greater than 30%. Today, in-hospital mortality is 6.5 to 7.5%. All of the following risk factors. In the USA, all of the following risk factors are decreasing except hypertension, smoking, hypercholesterolemia, diabetes. NCEP-ATP3 definition, 3 or more. Metabolic syndrome. NCEP-ATP3 definition, 3 or more. Abdominal obesity. WBC greater than or equal to 102 cm in men, 40 in, greater than or equal to 88 cm, 35 in, women. Serum TG greater than or equal to 150 mg/dl or drug Texas. Serum HDL. Men less than or equal to 40 mg/dl. Women less than or equal to 50 mg/dl. BP greater than or equal to 130/85 mm of mercury or drug Texas. Fasting glucose greater than or equal to 100 mg/dl or drug Texas. Points to remember: CV deaths have declined markedly since the 1960s. It continues to drop in men but not women. CVD is the leading cause of death but shifting from CAD to HF. Prevalence of risk factors decreasing in US except diabetes, vascular injury and atherosclerosis. Chronic inflammatory process that develops in response to injury. Metabolic environmental. Genetic. Physical infectious. Summary. Chronic inflammatory process that develops in response to injury. Lipoprotein accumulation and oxidation. Monocyte and T lymphocyte recruitment. Leads to plaque progression. Leads to endothelial dysfunction. Acute myocardial infarction, MI. Reduction in myocardial perfusion which is sufficient to cause cell necrosis. Most common mechanism of myocardial infarction. Thrombus formation in the coronary artery at the site of a ruptured, eroded, or fissured atherosclerotic plaque. Ruptured plaque exposes the thrombogenic lipids in the plaque to the blood which leads to activation of platelets and clotting factors. Coronary plaques most prone to rupture have a rich lipid core and a thin fibrous plaque. Acute myocardial infarction. Other rare causes of acute myocardial infarction. Coronary artery embolism from a valvular vegetation or intracardiac thrombus. Cocaine use. Coronary artery dissection. Anemia. Hypotension. Coronary spasm. Acute coronary syndrome. Unstable angina. Non-ST elevation MI. NSTEMI. ST elevation MI. STEMI, the spectrum of acute coronary syndromes. Unstable angina. Non-ST segment elevation me. NSTEMI. ST segment elevation me. STEMI. Anginal pain with at least one of the following features. Of new onset and severe. Occurs at rest or with minimal exertion. Pain is worsening in severity and length of each episode, and length of each episode, i.e., crescendo pattern. Characterized by clinical features of unstable angina in addition to elevated cardiac markers. Characterized by clinical features of myocardial infarction in addition to ST segment elevation on a 12-lead EKG. Characteristics of plaques prone to rupture. Thin fibrous caps. Lipid, macrophage rich. Smooth muscle pore. What accounts for the disparity between degree of coronary artery stenosis and producing the acute coronary syndromes? The functional state of the atheroma, not merely its size or the degree of luminal encroachment, determines the propensity for development of acute coronary syndromes. Triggers of plaque rupture. Emotional stress. Physical activity. Increased sympathetic tone. Triggers of plaque rupture. Heart rate and blood pressure. Vasoconstriction. High shear stress. Physical and emotional stress. Infection. Inflammation. In half of patients with STEMI, a precipitating factor or prodromal symptoms can be identified. Unusually heavy exercise in habitually inactive patients and emotional stress can precipitate STEMI. Accelerating angina and rest angina may culminate in STEMI. Respiratory infections, hypoxemia, cocaine use and non-cardiac surgical procedures can predispose to STEMI. Non-modifiable factors. Risk factors for ST elevation myocardial infarction and cardiovascular disease. Non-modifiable factors. Age. Male gender. Family history of cardiovascular disease. Risk factors for ST elevation myocardial infarction and cardiovascular disease. Modifiable factors. Cigarette smoking. Hyperlipidemia. Hypertension. Diabetes. Obesity. Physical inactivity. Diet. HSCRP. Controversial risk factors for me. Baldness. Gray hair. Diagonal earlobe crease. Frank's sign. Symptoms of acute myocardial infarction. Substernal chest pressure, usually described as heavy, squeezing, tightness, crushing and sometimes stabbing or burning pain, Levine sign. In STEMI, sudden onset of chest pain often associated with shortness of breath, diaphoresis, weakness, nausea and vomiting. The pain sometimes radiates to the C7, T4 dermatomes, left arm, shoulders, jaw, neck, back and epigastrium. Radiation to both arms is a strong predictor of acute ME. In 20% of patients, diabetics, elderly, postoperative or female, chest pain may be absent. Inferior leads equals 2, 3. AVF. Right coronary artery or left circumflex coronary artery. Anterior leads equals V1, V6. Left anterior descending coronary artery. Anterior infarct equals leads V2, V5. Anteroseptal infarct equals leads V1, V4. Anterolateral infarct equals leads V3, V6, I plus AVL. Lateral leads equals I plus AVL, V5, V6. Diagonal branch coronary artery. Obtuse marginal branch coronary artery. Intermediate ramus branch. High lateral leads equals I plus AVL. Low lateral leads equals V5, V6. Left main occlusion. SD elevation in AVR greater than 1 mm. SD elevation in AVR greater than V1. Widespread ST depression in multiple leads, most prominent in leads 1, 2, and V4, V6. SD elevation in AVR may also be seen with proximal lat occlusion and severe triple vessel disease. Reperfusion goals in SD elevation ME. PCI equals percutaneous coronary intervention. Primary PCI, door to balloon time less than 90 minutes. Primary PCI, first medical contact to device time less than 90 minutes. Primary PCI, when transferred from a different hospital, first medical contact to device time less than 120 minutes. Fibrinolytic therapy, door to needle time less than 30 minutes. Guidelines for primary PCI in STEMI. Class I. Primary PCI should be performed within 12 hours of onset of STEMI. Primary PCI should be performed within 90 minutes of first medical contact as a systems goal when presenting to a hospital with PCI capability. Primary PCI should be performed within 120 minutes of first medical contact as a systems goal when presenting to a hospital without PCI capability. Primary PCI should be performed in patients with STEMI who develop severe heart failure or cardiogenic shock and are suitable for revascularization as soon as possible. Guidelines for primary PCI in STEMI. Class IA. Primary PCI is reasonable in STEMI if there is clinical or ECG evidence of ongoing ischemia between 12 and 24 hours after symptom onset. PCI is reasonable in patients with STEMI and clinical evidence for fibrinolytic failure or infarct artery reocclusion. Time is muscle. In 2006, the American College of Cardiology launched the D2B Alliance, a campaign to reduce systems delay in the care of STEMI. As a result, median door-to-balloon times were reduced 32 minutes from 96 minutes to 64 minutes between 2005 and 2010. Pre-hospital ECG transmission to STEMI receiving hospital. Reduces door-to-balloon time. Chart review of STEMI patients between January 1, 2010 to November 25, 2010. Mean door-to-balloon time with a pre-hospital ECG was 53 minutes. Mean door-to-balloon time without a pre-hospital ECG was 77 minutes. P equals 0.0003. Catheterization and cardiovascular interventions 2011, 77:S1. Acute treatment of ST elevation ME. 4 aspirin 81 mg chewed. Plavix 600 mg. Heparin 5000 units 4. Morphine 4 as needed for pain control. Nitrates, and e.g., sublingual and 4, Contraindicated in RV infarct. Hypotension and severe bradycardia, HR less than 50. Metoprolol 4, contraindicated in CHF, hypotension bradycardia, first degree avenue block, evidence of low output, asthma, and increased risk of cardiogenic shock, in hospital treatment of ST elevation Me. Aspirin. Plavix, Effiant, or ticagrelor, Brilinta. Beta blocker, metoprolol or carvedilol. High-dose statin, atorvastatin. ACE inhibitor, lisinopril, for LF less than 40% and or pulmonary congestion. Aldosterone antagonist, aldactone, for CHF, complications of ST elevation Me. Cardiogenic shock. Right ventricular infarction. Papillary muscle rupture. Ventricular septal rupture. Free wall rupture. Heart block. Ventricular fibrillation/ventricular tachycardia/atrial fibrillation. Cardiogenic shock. 7% of acute Me. Decreased cardiac output with insufficient tissue perfusion in the presence of adequate intravascular volume. Clinical signs: oliguria, cool, cyanotic extremities, altered mental status. Hemodynamics: systolic BP less than 90, cardiac index less than 2.2 and pulmonary capillary wedge pressure greater than 15. Causes of cardiogenic shock: severe LV dysfunction, extensive RV infarction, mechanical complications, acute MR due to papillary muscle rupture or dysfunction, ventricular septal defect, free wall rupture, development of cardiogenic shock. Risk factors for the development of cardiogenic shock: elderly, age greater than 70. Diabetes. Anterior infarction. Prior Me. 3-vessel or left main coronary artery disease. Early use of beta blockers in large infarcts, right ventricular infarction. Usually occurs in association with inferior infarction. Clinical findings include shock with clear lungs, elevated jugular venous pressure, small sign, and pulsus paradoxes. EKG, ST elevation in right-sided leads V4R, V5R or V6R. Hemodynamics, elevated right atrial pressure greater than 12. Normal to low pulmonary pressures. Pulmonary capillary wedge pressure less than 15. Management, volume expansion with normal saline 4. Prompt reperfusion, nitroglycerin is contraindicated. Acute mitral regurgitation. Papillary muscle rupture, 90% associated with inferior infarction. Acute pulmonary edema/cardiogenic shock. Murmur of MR may be minimal or absent. Diagnosis with echocardiogram/transesophageal echocardiogram. Treatment with intra-aortic balloon pump, nitroprusside and or dobutamine, mitral valve surgery ASAP. Ventricular septal defect. 55% due to inferior infarction, 45% due to anterior infarction. Acute onset of ventricular CHF or cardiogenic shock. Holosystolic murmur and a precordial thrill. Diagnosis with echocardiogram. Treatment with intra-aortic balloon pump, nitroprusside and or dobutamine, eventual surgery. Very high mortality. Free wall rupture. LAD, diagonal or left circumflex coronary artery myocardial infarctions. More frequent in elderly patients with a history of hypertension. Usually presents as a catastrophic event, P due to tamponade. Syncope and cardiogenic shock are also common. May have pleuritic chest pain, nausea or restlessness. Diagnosis with pericardial effusion seen on echocardiogram. Treatment with emergency surgery, intra-aortic balloon pump, peak time periods for me. 6 a.m.-12 noon. Monday is the most common day of the week. Top 3 peak days for me are Christmas Day, the day after Christmas, and New Year's Day. Spikes in incidence during major sporting events, Super Bowl or World Cup. Spikes in incidence with natural disasters, earthquakes, hurricanes, etc. Recent studies have shown an increased risk of me after angry outbursts, higher risk of me in the morning. Surge of stress hormone, cortisol, in the morning. Surge of fight or flight, catecholamines, in the morning. Higher blood pressure and heart rate. Platelets are more adhesive to the vessel wall in the morning. Natural fibrinolytic system in the body is less active in the morning. Higher risk of me in the winter, multiple factors account for this. Blood vessels constrict and the blood clots more readily in cold weather. Shoveling snow is a frequent trigger of me. In Australia, peak me incidence is in June. Florida, Southern California, and Hawaii also have a peak incidence of me in the winter months. Higher risk of me in the winter. Multiple factors account for this. Inflammation can trigger a me by making the coronary plaques less stable. The flu and respiratory infection cause significant inflammation. The flu season peaks in the winter months in concert with peak incidence of me in winter. People eat more, exercise less, smoke more, have more stress, and gain more weight during the holiday season. Higher risk of me in the winter. Multiple factors account for this. Shorter days with less UV radiation, which leads to lower vitamin D levels. Less sunlight and shorter days lead to depression and seasonal affective disorder. People with depression are at an increased risk for developing heart disease. Blood pressure and weight both increase in the winter. The perfect storm for a heart attack. It is Monday morning, the day after Christmas. You are suddenly awakened at 6 a.m. to the shaking and rattling of an Oklahoma earthquake. Because of the surprise of the earthquake, you forget to take your aspirin, Plavix, Lipitor, metoprolol and metformin. You are angry and depressed because you have just recovered from the flu and you have gained 10 pounds, and you have to go back to work at a high-stress job. You have a fight with your father-in-law because he is invading your space and getting on your nerves. For comfort, you eat a large piece of pecan pie and drink a large glass of eggnog for breakfast, and then you smoke a cigarette. At 7 a.m., you go out into the freezing cold to shovel a foot of snow off of your driveway and it is a full moon. We all know what happens next. "50 patients with recent STEMI were randomized into 2 groups. 24 enrolled in a 6-month exercise-based cardiac rehab program, Group T. 26 were discharged with generic instructions for maintaining physical activity and correct lifestyle, Group C. All patients had an exercise myocardial perfusion study and a cardiopulmonary exercise within 3 weeks after STEMI and at 6 months. European Journal of Preventive Cardiology 2012 December, 19, 6/14/10-14/19. At follow-up, the cardiac rehab group, Group T, had a significant reduction of stress-induced ischemia. P less than 0.001. Improvement in resting and post-stress wall motion. P less than 0.005. Improvement in peak oxygen consumption, P less than 0.001. At follow-up, the generic instructions group, Group C, had no change in myocardial perfusion parameters, LV function, and cardiopulmonary indexes. Secondary prevention: 10 aspects of treatment smoking diabetes. blood pressure control, antiplatelet agents/anticoagulants, lipids, RAS blockers, physical activity, influenza vaccine, weight. Benefits of cardiac rehabilitation: 20 to 30% reduction in all-cause mortality rates. Decreases mortality at up to 5 years post-participation. Reduced symptoms, angina, dyspnea, fatigue. Reduction in non-fatal recurrent myocardial infarction over a median follow-up 12 months. Benefits of cardiac rehabilitation: improves adherence with preventive medications. Increased exercise performance. Improved lipids, total cholesterol, HDL, LDL, and triglycerides. Improved knowledge about cardiac disease and its management. Enhanced ability to perform activities of daily living. Benefits of cardiac rehabilitation: improved health-related quality of life. Improved psychosocial symptoms and increased self-efficacy. Reduced hospitalization and use of medical resources. Return to work or leisure activities. Summary: in the USA, cardiovascular deaths have declined markedly since the 1960s. Rates of death from CHD have declined in most high-income countries but are increasing in the developing world. In the USA, the prevalence of risk factors are all decreasing except for diabetes. Atherosclerosis is a chronic inflammatory process that develops in response to injury. Most commonly, STEMI occurs secondary to plaque rupture or plaque erosion with total occlusion of the coronary artery with thrombus. Coronary plaques prone to rupture have a thin fibrous cap with a lipid-rich core with a lot of inflammation, T, lymphocytes and macrophages.